I'd like to thank SAGES as well as Dr. Soper and Dr. Santos for the invitation to speak today. And after hearing Dr. Mirza's talk, I'm not sure I have much more to add. He should be congratulated for setting up such a program, and I think that's what we should aspire to at our institutions in the United States and elsewhere. And so, that's a very mature program that they have, but I think most of our programs in the U.S., and I'll speak for ours, is much less mature. And I'll share some thoughts about what we've done at Northwestern to help try to combat this deficit and how to address the bile duct and bring particularly laparoscopic common bile duct exploration back to the forefront. I don't have any pertinent disclosures, and in the interest, I know as the last talk, I'll probably have a lot of redundancy here in what's been presented through the day. But I think I just want to emphasize a couple of things again, and go over this, because I don't think it can be emphasized enough, is that choledocholithiasis is definitely something that's been that is very common, and that we've really lost control of the management of these patients. Dr. Ratner talked about the open common bile duct exploration, and really that was in the era of but this was really the only option in the 80s, 90s. Is really when laparoscopic common bile duct exploration and ERCP came on, where the paradigm shifted. And unfortunately, ERCP now has really dominated the way that common bile duct stones are addressed in the United States. So for ERCP, it's for well-trained endoscopists, the clearance rates are very good. It's an endoscopic procedure, relatively not that invasive, but it does add some significant things to the care of patients, particularly that it involves an extra procedure, at least one extra anesthesia, and with a morbidity that has been reported up to 15%. Some of the larger ERCP series show much lower rates of complications and mortalities, but that's not necessarily reflected in what goes on in every hospital. One of the worst cases that I ever saw as a resident was a post-ERCP pancreatitis patient who died for an unnecessary ERCP. I've just there was just an emergency consult several weeks ago for, again, a perforation for, again, a relatively unnecessary ERCP at our institution. And at the Children's Hospital, there was a 14-year-old adolescent who had an ERCP done that probably could have been handled otherwise, and there was a significant hemorrhage requiring 20 units of blood, emergent laparotomy. And these cases do happen, and when they do, they're devastating. And so we need to potentially think about another choice, if there's a better way potentially of doing this. And like we heard in the other talks today and the last talk, that laparoscopic common bile duct exploration can be a very viable alternative for this. And in well-trained hands, it's been shown to be very effective and have comparable clearance rates. It's very funny that if a lot of times we're asked, what about level one? What about level one evidence? Well, there's strong level one evidence that laparoscopic common bile duct exploration is as good, if not better, than ERCP, in that it has shorter lengths of stay, decreased number of procedures, it's more cost effective. It requires some advanced skills. It does take some logistics. It is very crucial to have a team that is willing to go through this. But the reality is that the current training paradigm is inadequate, and there are some other potential logistical things, such as just how you're doing elective lap chole, and then you got 4 other cases after to follow, and all of a sudden you have a common duct stone, and you're going to extend your day to 2 hours, et cetera. Is that a reason to not do it? No, it shouldn't be, but the reality is that it is. And there's potentially also inadequate reimbursement. So you add the 4 extra RVUs that you bill for a lap common bile duct exploration at whatever, $30 to $60 per RVU. Is that worth it for some of the surgeons? And so that may be a potential contributing factor. And so as a result, 7%, only 7% when Dr. Palouse presented or showed this paper or published this paper in 2006, at that time, only 7% of common duct stones were addressed laparoscopically. We recently looked at a more current data set for this. It's not published yet. It was presented at the Pacific Surgical, and the number of inpatient admissions nationwide for common duct stones has been very stable over the last 20 years or so. But the numbers continue to decrease, and so the rate of laparoscopic common bile duct exploration, and all common bile duct exploration, is in the single digits. Dr. Palouse also recently, and his group recently published some surgeon attitude data to look at this as well. They sampled 771 surgeons, and they looked at what are some of the factors for doing preoperative. If you knew a preoperative common duct stone, that 86% of those surgeons preferred in ERCP. So again, if you knew you had a stone preoperatively, again, 86% are going to ERCP. What were the factors that increased that? If you practiced in a metropolitan or in a metropolitan practice, potentially with a residency program. If you had availability of a reliable ERCP, that decreased your likelihood of going for laparoscopic common bile duct 90%. And if you were a person who described themselves as a selective IOCer, so you're a selective IOCer, before you even go to the operating room, again, you were 70% less likely to take care of it in the operating room, and you were more likely to refer to ERCP. Dr. Bell published this important paper back in 2009 showing, again, the number of laparoscopic common bile duct explorations, or even any common bile duct explorations that were performed by a graduating chief resident was in the single digits. The mean was less than 1. So actually, Dr. Santos here was a resident in my lab about 5-6 years ago. And he said, I don't know how to do this. And so I want to learn how to do it. And so he decided, and with the support of a SAGES research grant, we developed a laparoscopic common bile duct simulator and a procedural rating scale, and demonstrated that the rating scale produced valid and reliable data. Dr. Teitelbaum, Dr. Santos's follower in the lab, developed a mastery learning curriculum based on simulation where we were able to demonstrate that if you took naive residents that have never seen common bile duct exploration before, that you could train them to mastery standards. This is, for those of you who are going to be doing the hands-on course later this afternoon, you'll have an opportunity to work on this simulator. And we designed it to mimic a laparoscopic common bile duct exploration as best we could. We needed both. We need all the views. We need the laparoscopic view. We need the cholangiographic view, as well as a simulated fluoroscopic view. And so, at Northwestern, we've made this a priority for our residents to learn how to do this. Every PGY 3, 4, and 5 who rotate on our service, it's a requirement for them to finish the MIS rotation. Again, this is we put them through this curriculum, this mastery level standard curriculum, where they go through a pre-curriculum test, they go through a curriculum with deliberate feedback, hands-on training, and then undergo a post-curriculum test, and then if needed, can retest if needed. Recently, we wanted to see what the effect of such training has had at our institution, and to see how we could potentially impact and roll out that curriculum elsewhere. So since 2012, we've trained all the senior residents. Initially, it was just resident one-on-one with a faculty member. We started then incorporating team training into this because, again, I think this goes back to, again, it's much more important than just a surgeon wanting to do it in the operating room as it is a team willing to help take care of the patient the best way. And so we paired each resident with an OR nurse. So all the OR nurses now have been trained on the simulator as well. Because, again, it's not so much that the operation itself is not very difficult, but it's the steps and knowing which, what equipment needs to be open, the order it needs to be open, and how to just working through it stepwise. And then we took it one step further. We took those PGY 3s and 4s who are now chief residents, and they trained the next generation, so the years behind them. And so it's kind of a feed forward, so they actually see one, do one, teach one on the simulator, and then how does that potentially translate into the clinical realm? So before the simulator curriculum was developed, the number of common bile duct explorations, as Dr. Santos was experiencing, was abysmally low. So maybe one a year, maybe two a year. And then once we've initiated the curriculum, the number of cases of common bile duct exploration has significantly increased over this time frame. Now, the absolute numbers might be still low in the 10 to 15 cases per year, but that is a significant increase. And again, once you do one of these or two of these, you realize it's not rocket science, and you can go ahead and you can usually reliably and confidently move forward. Some of this data is going to be presented by Dr. Ezra Teitelbaum at the Posters of Distinction session later, and so I don't have all the data here. I don't want to steal all of his thunder, but I would encourage you to attend his talk as well. Most of the attendings that were, so again, once the residents have done this and have achieved this mastery standard, what's happening is when they are on the emergency acute care surgery service, they're the ones now that are driving this. They're asking to do it. Can we do it? And attendings who have no prior experience necessarily in laparoscopic common bile duct exploration are actually the ones that are doing the case, even though the chief residents are really driving it. And so we've increased the percentage of common duct stones that the residents come across from handled by lap common bile duct exploration from 2 to up to 8.4%. So this is just the beginning stages of something that I think that we can continue to move forward. This just looked at some of the clinical outcomes data for those cases that were done by the residents, and we had a 96% stone extraction rate, which is very good. And we've taken a look at some of our preliminary cost data from the hospital, and we've been able to extract and finally convince them to actually give us some real cost data. And since the curriculum was developed or put in place, these are the average case costs and charges moving forward. So there's about a $3,000 cost savings for approaching a patient with common bile duct stones with a single-stage laparoscopic common bile duct exploration, as opposed to sending them to ERCP. So I hope that we've demonstrated that you can train residents or attendings in laparoscopic common bile duct, a single-stage approach, and it can be safely done. I think the real question is, how do we move this forward? How can we engage this sort of thing from a more nationwide training regimen? And I think Dr. Merzer hit the nail on the head as far as really having SAGES or the American College of Surgeons champion this movement. I think SAGES, has done a good job with bile duct, safe cholecystectomy, but I think we need to take that now to the next level and reclaim the bile duct. I think it has to be done at an institutional level too. I think it takes a Dr. Soper who is willing to give the residents protected time to go down to the simulation lab. I think it takes rotation coordinators such as myself and making it a required part of the course. I think we also need to think about cholangiography. I mean, again, there's obviously now data to suggest that if you're a selective cholangiographer, you're going to potentially, miss a bunch of cases and not help patients the way you potentially could. And so I would advocate for routine cholangiography. And if you are going to do selective cholangiography, you have to have a very low threshold. So if there's any ductal dilatation, if there's any evidence of LFT abnormalities or increase in bilirubin, there's no reason not to do an IOC. Now, unfortunately, I think that a lot of these barriers to laparoscopic common bile duct exploration are only going to be overcome unless there's greater institutional incentive or individual reimbursement incentive, or the insurance companies get involved, and because we all think that potentially bundled payments are going to come down the pike. So institution's going to get $20,000 to take care of a common duct stone. It's going to be the institution's responsibility to how to best allocate those funds. And if you could train the next group of surgeons to do this reliably, safely, and cheaper, I think it's going to be driven, and I think that's what's going to ultimately going to drive this. We did have an institutional simulation research grant through the Alvin H. Baum Foundation, and with that, thank you very much.